What if the test your doctor just ordered, the one meant to protect you, is actually the thing most likely to send you to the hospital? I know that sounds backwards, but after 15 years working almost exclusively with patients over 60, I've watched it happen more times than I can count. A perfectly healthy person goes in for a routine check. They come out with a diagnosis they didn't have before, and a life that is suddenly defined by doctors' offices, procedures, and fear. Today, I'm going to show you exactly how that happens, and more importantly, how to make sure it doesn't happen to you. My name is Dr. Gregory Holt. I've spent over 15 years focused specifically on the health of adults over 60, and I can tell you honestly, some of the most important conversations I have with my patients are not about what tests they should get. They're about the tests they should think twice about. In the next few minutes, I'm going to walk you through 5 medical tests that sound like common sense but regularly cause more harm than good in people your age. I'm going to explain what goes wrong, why it keeps happening, and what smarter alternatives actually look like. This isn't about avoiding your doctor, it's about walking into that office informed, empowered, and ready to ask the right questions. Quick disclaimer before we dive in. Everything I share here is for educational purposes only. It is not a substitute for professional medical advice, and it is not meant to replace a conversation with your own physician. Every person's situation is unique. If something I say resonates with you, bring it to your doctor and have that conversation. That's exactly the point. Better conversations lead to better care. Now let's get into it. Medical Test 1, the annual full panel blood test that turns healthy people into patients. Here's a scenario I see constantly. Someone comes in for their yearly physical. They feel great, sleep is decent, energy is okay, no major complaints. We run a standard blood panel, and one number comes back slightly outside the normal range. Maybe it's a thyroid number, maybe it's a liver enzyme, maybe it's a slightly elevated PSA, and now everything changes. The patient, who walked in feeling perfectly fine, walks out with a printout covered in flagged items and a referral to a specialist. Within a month, they're on a new medication. Within 3 months, they're getting follow-up labs every 6 weeks. Within a year, they've built an entire identity around managing their condition. A condition that, in many cases, would never have caused a single symptom if they'd never found it. Here's what most people don't realize about blood test reference ranges. Those normal ranges are calculated from large populations that include people of all ages. When a 67-year-old's result falls outside a range designed for a 35-year-old, it doesn't automatically mean something is wrong. It often means you're 67. Kidneys filter a little slower. Hormone levels shift. Certain enzymes fluctuate. These are biological facts of aging, not diseases. The problem is that lab software flags anything outside the range in red, and that red flag triggers action almost automatically, regardless of whether action is actually warranted. I call it the red flag reflex, and it's one of the most reliable ways a healthy older adult ends up over-medicated. What to do instead? When you get a result that's flagged, ask 2 questions. First, how far outside the range is it? A borderline result and a dramatically abnormal result are completely different things. Second, has this number been trending, or is this the first time we've seen it? A single, slightly off reading is almost never worth a cascade of intervention. Context is everything. Stay with me. Point 2 is one that almost nobody talks about, and it surprised even some of my colleagues. Medical Test 2, bone density scans that lead to medication. You probably don't need osteoporosis screening. The DEXA scan sounds like pure common sense. You're over 60, your bones might be losing density. Catch it early. Simple, right? Here's where it gets complicated. The scan gives you something called a T-score. A score between -1 and -2.5 is labeled osteopenia. Below -2.5 is osteoporosis. These labels sound clinical and serious, and so, predictably, many people who get a result in the osteopenia range are immediately started on medications called bisphosphonates, drugs like Fosamax or Boniva. Now here's what I need you to sit with for a moment. Osteopenia is not a disease. It is a statistical label that means your bone density is lower than the average 30-year-old at peak bone mass. You are not 30. You have never been supposed to have the bones of a 30-year-old at age 68. Think of it this way. If we measured everyone's hearing against the benchmark of a 25-year-old, virtually every person over 60 would be diagnosed with hearing loss. That doesn't make it a pathology that needs aggressive treatment. It makes it a normal part of aging. The research on bisphosphonate medications for osteopenia, not osteoporosis, osteopenia, is genuinely mixed. In people with true osteoporosis and a documented high fracture risk, these drugs have clear benefits. But for the much larger group of people with osteopenia and no prior fractures, the benefit is modest at best and the side effects are real. Jaw problems, atypical fractures of the femur with long-term use, GI distress, and a false sense of security that leads people to skip the interventions that actually work best. What to do instead? If your DEXA scan shows osteopenia, the most powerful things you can do are not pharmaceutical. Resistance training, lifting weights, using resistance bands, even bodyweight exercises, directly stimulates bone formation. Adequate protein, vitamin D and calcium from food where possible, and balanced training to reduce your actual risk of falling, because the fall is what breaks the bone, not the density number on a piece of paper. If your result shows osteoporosis, especially if you've had a fracture, that's a real conversation to have with your doctor about whether medication is right for you. But osteopenia alone, don't let a label push you into a treatment pipeline you don't need. Coming up, point 3 is one that affects millions of men over 60, and it's been quietly causing unnecessary suffering for decades. Medical test 3, routine PSA testing after 70. That opens a door you can't close. Let's talk about the prostate-specific antigen test, the PSA. For men, this is one of the most routinely ordered blood tests starting around age 50, and its purpose is real. PSA levels can help detect prostate cancer. But here's the part of the story that doesn't make it into the conversation often enough. Prostate cancer is extraordinarily common in older men. Autopsy studies of men who died of completely unrelated causes, show that somewhere between 60 and 70% of men in their 70s and 80s have prostate cancer cells present in their prostate gland. The overwhelming majority of those cancers will never cause any symptoms, will never spread, and would never have shortened their life by a single day. Doctors call them indolent, essentially harmless. The problem with PSA testing after age 70 is that we are very good at finding these harmless cancers. We are not very good at distinguishing them from the rare aggressive ones. So what happens? The PSA is elevated. There's a biopsy. Cancer cells are found. And now the patient, who felt completely fine, is labeled with cancer. The psychological weight of that word alone is devastating. And then comes treatment, surgery, radiation, each of which carries significant risks of incontinence and erectile dysfunction. Side effects that permanently alter quality of life in pursuit of treating a cancer that, statistically, was never going to cause harm in the first place. I've sat with patients who told me, in retrospect, they wish they'd never gotten that test. Not because the diagnosis wasn't real, it was, but because the treatment left them changed in ways they weren't warned about. And the cancer, based on how it behaved, probably would have sat there quietly until something completely unrelated ended their life at 88. What to do instead? For men over 70 with no symptoms and no family history of aggressive prostate cancer, the conversation around PSA screening should be an honest one. Shared decision-making means your doctor sits down with you, explains what a positive result will and won't tell us, and lets you decide based on your values. If you value early detection above all else, that's a legitimate choice. If you value quality of life and want to avoid the treatment cascade, that's equally legitimate. You deserve that conversation, not just a checkbox on a form. Keep watching. Point 4 is going to change how you think about a test that's been sold to you as the gold standard of preventive care. Medical test 4. Carotid artery ultrasound in people with no symptoms. You may have seen this one marketed at health fairs, community events, or through your local hospital. A quick ultrasound of the arteries in your neck, checking for plaque buildup that could put you at risk for stroke. It sounds like exactly the kind of proactive care we should all be getting, and here's why I want you to slow down before saying yes to it. The test itself is harmless. It's just sound waves. The problem is what happens with the results. When a carotid ultrasound finds mild to moderate plaque buildup, which it will in the majority of people over 65, because plaque is a normal part of vascular aging, the cascade that follows is remarkably predictable. More imaging, referral to a vascular surgeon, discussion of a procedure called a carotid endarterectomy, where surgeons remove plaque from the artery. Here's the critical detail. For people with no symptoms, no stroke, no TIA, no warning signs, the research shows that this surgery does not reduce stroke risk better than aggressive medical management, meaning medication, diet, exercise, and blood pressure control get you to the same place without cutting open your neck. But the surgery carries real risks: stroke during the procedure, heart attack, nerve damage. It's not trivial. And yet, once a patient knows plaque is sitting in their carotid artery, the pressure, psychological and medical, to do something becomes almost irresistible. What to do instead? Focus on stroke prevention through the levers that actually move the needle. Blood pressure control is the single most powerful thing you can do. Keeping your numbers below 130/80 dramatically reduces stroke risk. Full stop. Don't smoke. Eat a Mediterranean-style diet with plenty of vegetables, olive oil, fish, and whole grains. If you have atrial fibrillation, work with your doctor on appropriate anticoagulation. These are the interventions backed by overwhelming evidence, and none of them require knowing the exact millimeter measurement of plaque in your neck. One more point to go, and this one ties the whole conversation together in a way I think you'll find surprisingly reassuring. Medical test 5, follow-up. Imaging for incidental findings that were never the problem. This one is slightly different from the others because it's not about a single test. It's about what happens after a test, and it's the most common way I see healthy older adults get trapped in a medical system that doesn't know when to stop. Here's the scenario. You have a CT scan for something completely unrelated. Maybe they're checking on an appendix or looking at your lungs after a bout of pneumonia. The doctor reviews the scan and everything they were looking for is fine, but the radiologist, whose job is to describe everything visible in the image, mentions something else. A small nodule, a cyst, an area of haziness, something incidental, meaning they found it by accident, not because it was causing any problem. The report says, recommend follow-up imaging in 6 months. And just like that, you've been handed something to worry about. Here's what I want you to hold on to. Incidental findings in older adults are the rule, not the exception. Studies show that in people over 65 who get any kind of cross-sectional imaging, CT, MRI, full-body scan, the majority will have something flagged as an incidental finding. A small lung nodule, a kidney cyst, a liver hemangioma, a bone island. These things accumulate over a lifetime. They are biological footnotes, not chapter headings. The problem is that once they're in your chart, they generate a kind of institutional momentum. Every future scan will mention them. Every new doctor who reads your file will feel obligated to address them. And each time they're addressed, there's a chance, a real chance, that the follow-up process itself will cause harm. I had a patient, a 74-year-old woman, sharp, active, genuinely healthy, who came to me in a state of constant anxiety. 3 years earlier, a CT scan had found a 6mm lung nodule. Since then, she'd had 4 more CT scans, a PET scan, and a bronchoscopy. Everything kept coming back benign, but by the time I met her, she'd stopped traveling, stopped exercising the way she used to, and was convinced she was living on borrowed time. The nodule hadn't hurt her. The chase had. What to do instead? When you receive a report with an incidental finding, ask your doctor directly. If we watch this and it stays the same, what's the realistic worst-case scenario? And what's the realistic best-case scenario of intervening? Get that risk conversation on the table explicitly. In many cases, a surveillance plan that involves one follow-up scan, not an endless series, is completely appropriate. In many other cases, the right call is to document it, note that it's stable, and move on with your life. Your scan result is not your identity. A finding is not a diagnosis, and a diagnosis is not a death sentence. Context, always. So let's pull this together quickly. 5 tests that deserve a second look after age 60. 1. Routine blood panels that flag age-normal results as diseases and push you toward medication you may not need. 2. Bone density scans that label normal aging as osteopenia and put you on a medication pathway before lifestyle changes have even been tried. 3. PSA testing after 70, where finding an indolent cancer can cause more harm than the cancer ever would have. 4. Carotid ultrasounds in people with no symptoms, which routinely trigger surgical conversations for plaque that medical management handles just as well and more safely. And 5, the follow-up imaging spiral for incidental findings that turns a footnote into a years-long source of anxiety and unnecessary procedures. The common thread in all of them? The cascade. One result leads to another test, leads to a referral, leads to a procedure, and somewhere in the middle you stop being a person and start being a collection of findings to be managed. The antidote is not avoiding medicine, it's asking better questions, understanding what you're signing up for before you say yes, and measuring your health not by what your tests show, but by what your body can do. Can you walk up the stairs, get up from a chair, sleep through the night, enjoy a meal with people you love? That is health, not a perfect lab panel, not a clear scan. If this gave you something to think about, or something to bring up with your doctor, I genuinely appreciate you subscribing. I do this every week because I believe you deserve honest conversations about what medicine can and can't do for you at this stage of life. No hype, no selling, just the information that helps you make better decisions. Take care of yourself, and remember, the best healthcare decision you ever make might be the one you slow down enough to actually think about. See you in the next video.